thank you.
Yeah.
So my name is Mr. Dingra. I'm a consultant ophthalmologist at MYHT. I've been a consultant now for nearly 11 years here. And I've been sitting on the National Recruitment Panel for Ophthalmology Selection for the last 5 years. So I thought it would be a good idea to give you a brief overview of what a career in ophthalmology looks like and how do you actually join the training stream to become to get onto the specialty training. So can you move the next slide, please? So the first question. Ash, can you move the next slide? Yeah. So the the first question that's asked is why ophthalmology? So for me, ophthalmology is a great specialty because it actually brings in lots of medical knowledge, uh, which is in common with general medicine. In addition, it also has the additional benefit that you're not leaving your surgical core specialty altogether. So it's a great combination of medical and surgical. In addition, people who choose not to operate also have an option to become medical ophthalmologists. So there's a stream called medical ophthalmology, and it's great because it actually allows you to keep a good work-life balance. Now, for me, my general work involves doing some clinics, some research, some audits, and I have a couple of surgical sessions every week. So it gives a good balance of what you can do. Now, to get into the ophthalmology training, there are certain things that you need to be doing. There are various stages of recruitment. The first thing is everybody needs to just fill in application form, which is online, which is just basically a tick box exercise to say whether you've got GMC, whether you've got license to practice, whether you've met all your foundation training program competencies, just to make sure that before, even at the very first step, you can be stopped. So you complete the application form online. There's no free text allowed there. And then what's called the long listing. So that means everybody who fills in that form completely moves to the next stage of application. And there's no shortlisting at that stage. Then comes the selection criteria. So a lot of you may have actually heard about this multi-specialty recruitment assessment, which is not just specific for ophthalmology. I think Ops and Gynae and radiology and few other specialties also use it. And that gives you a maximum score of 20. I'll just give you a brief example of that. The whole, you have to score out of 100, and the MSRA has a maximum score of 20. The evidence folder, as you can see, gives you the bulk amount of scoring. So you need to do really, really well in your evidence folder. If the evidence is not there, if it's not uploaded, that means even if you have mentioned it, it is not existent and I don't score anything for it. And then the final stage is the interview. Again, the interview is online and I'll just give you some examples of that. So 20, 50, and 30. Move to the next slide, please. So requirement to get into ST1 is that you need to be MBBS or equivalent. You should have full GMC with license of FT competencies. Again, that's where the long listing comes in. If there has been any concern about fitness to practice, then there should be an undertaking form that can be filled in. And also you need to show your career progression. That means what have you done since you left med school? All your clinical posts, all the FY1s, all the FY2s, jobs that you've done needs to be put in chronological order. It's very important and harp on this all the time. If you have done more than 18 months of ophthalmology, then you can't be chosen for ST1 jobs. There is a stream where ST3 applications can come through, where people who have done more than 18 months of ophthalmology can try to get in, but that's equally competitive, and the Royal College is thinking of doing away with that because there are only about 8 seats at ST3 levels. At the level of ST1, there are about, this year, there were about 63 seats. And the number of applicants, just to give you a rough idea, was about 654. uh, the the personal specifications are available on the all the ST1 for ophthalmology are run by the Severn Deanery website. So if you go to Severn Deanery website, all the personal specifications are easily available. Next slide, please. So the first step, as I said, is the long listing where you just need to fill in that you meet the entry criteria, that you've done all your foundation training competencies. And at that stage, there's not significant rigorous check done because we believe that everybody who has applied for that role have already done all the competencies. However, if there are any concerns, we can check at that time, or we can also come back after you've gone through the whole process. Next slide. I said to you about the experience within ophthalmology. So I said to you at the time of the interview, you should not have had done more than 18 months in ophthalmology. For applicants, because we have had 2 rough years with COVID, so people have been redeployed and gone to do something else. So that can also be considered. So exceptions have been made this year for people who are redeployed to do other things other than ophthalmology. However, if that's been the case, then exception forms are available in the website when you fill your application form to say, I did ophthalmology for more than 18 months because of so and so reasons. And then that will be given a considerate hearing, provided it meets the requirements. If you have done 24 months in ophthalmology for no other need, for no other reason, then unfortunately your application form will not be considered. Next slide. The MSRA, again, I'm not going to go into the detail because I'm sure some of you may have already seen it while looking at the competencies for other specialties. You have the professional dilemma, PD, and you have the clinical problem solving. So the PD is like your SJT, situational judgment, that you have already done previously, 50 questions, 95 minutes, and clinical problem solving, 97 questions, 75 minutes. And again, you just need to achieve a threshold score to get to the next stage. You don't need to, there's no pass or fail mark. There's a threshold score. If you do well, there are 20 marks for this. 20% of your scoring is done in MSRA. So the better you do, the increase your chances of getting to be selected. Thank you. Next slide. Now, coming to the evidence folder. Now, this is one thing which I need to slightly go more in detail, because this is where a lot of people who are applying for a lot of medical students or a lot of foundation training who's come and sit with me in the clinic ask me questions on what to do. So each domain that I'm going to go through has marks, and your job is you have to ensure that you try to get the maximum marks in each domain. If you leave a domain empty or don't fill anything in the domain, you are reducing your chances of getting selected. So the domain of listing of previous posts, again, there's no mark for that. You just say what you've done since you left med school. Now for qualifications, so if you have done MBBS is obviously a minimum entry requirement, so there's no marks for doing MBBS. However, if you've done an intercalated degree, you get 1 point for it. If you've done MD thesis, that means you spent a couple of years doing thesis, then you get 2 points. If you spent PhD or DPhil, you get 3 points. And the maximum is 4 points in this domain. In the next section is about the prizes and awards. Again, 1 point if you have stood first in your undergrad degree. If you've had a good poster or a presentation where you have won the best paper or the best poster, you get a point. If you have, a lot of people have done a Duke Elder exam because that's undergraduate exam that a lot of people who think of choosing ophthalmology as a career do. However, you need to do well in the exam. So if you are in the top 10 percentile, then you get 2 points. But if you get in the top 60, you get only 1 point. However, if you just pass the exam, you get 0 points. So you need to be doing really, really well and make sure that you're either in the top 10 or top 60. If you have done, okay, we'll come to the next point. So next slide, please. Thank you. The next domain is the one which scores the maximum number of points. You need to do really, really well and should not leave any of these empty. And I just did the, in the month of January, I did a selection and looked at the evidence, and one person just left this whole box empty. So that is 12 marks gone already of your 100 marks. So there are 12 points for this. So you need to do really, really well. And I think most of you, if you are serious about a career in ophthalmology, can do well if you do these things in a timely fashion. So for example, spending a taster week in ophthalmology. So come and spend time, or even spending time out of hours. So for example, if you have days off and you come and spend your time with us in ophthalmology, you get point for that. Spend a full week, you get 1 point for it. You attend a meeting, whether it's national, regional, or international meeting, you get a point, depending on what sort of meeting it is. Now, there's a lot of advantage to the people who put in their application in the last 2 years, because all the meetings were online. So you could attend an international meeting sitting at home rather than having to travel anywhere, and you got 3 points for it. And similarly, you can attend so make sure that you attend any opportunity to attend any regional meeting in ophthalmology, or there are a lot of meetings here in Yorkshire region itself. We have Yorkshire glaucoma meeting, we have Yorkshire retina meeting, you have the North of England meeting in ophthalmology. So you can attend all those meetings, and all those meetings do carry point. In addition, if you have actually passed part 1 of FRC Opt. Now, part 1 in FRC Opt is a difficult exam, requires a lot of basic ophthalmology reading, but it gets you 3 points. And there are a lot of time people who have done this and who get those points. In addition, if you have actually published, for example, I know a lot of medical students publish in non-peer-reviewed journals. So, for example, if you're sitting, let's say, in Cambridge, and you're publishing in Cambridge Journal or Oxford Journal, or wherever you are sitting in the hospital journal, or if you're even on a website, if you're publishing something, you still get a point for it. However, it goes into the specialty links and commitment to ophthalmology rather than in your publication section, because in publication section, we just look at peer-reviewed journals, but anything that you're published in ophthalmology related, even if it is on a public website or to disseminate the knowledge of disease in ophthalmology, you still get a point for it. So as I said, this domain is quite wide, and it gives you have maximal potential to get as many as 8 to 9 points in this domain. Thank you. Next slide, please. MSF. Now, all of you have had experience of MSF, or team assessment of behavior, as it is called. Now, MSF is important. Now, as you can see, there are 5 points for MSF. Now, it's important that the MSF should have taken place within 18 months of the interview date. Any MSF earlier than that, we don't give you any point, and you can easily lose points on this. So make sure that your MSF is dated, signed by your clinical supervisor. And the important bit in the MSF is, how do you actually score points in MSF? So you score points, for example, because I have got the scoring criteria, I know. So if you just if somebody says Dr. A is good, he is in time, he is punctual, he does what he's told, that is the basic MSF. You'll get 1 point for it. The more the superlatives are written about you, the more somebody writes about you, the more positive comments you have, your points keep increasing. If you have lots and lots of superlatives, lots and lots of positives, you get the maximum point. So I think it's important that wherever you go, wherever you get your If you have, for example, if you have 2 MSFs, which are all within 18 months, only one MSF needs to be put in, but you has got more positives to make sure that put only that one in marks. Next slide, please. With regards to publication, now you get points only if you are within the first 4 authors of a journal article. If you're 4th and on, you get no points at all, fortunately. And the way the points are given is based on where your authorship criteria is. If you're number 1, you get, if you are number 1 author in an international journal, you get maximum points. If you're number 2 in an international journal, you get half those points, and the number half as you move in the authorship criteria. So if you have an original article, international journal, and if you're the first author, you have already secured the maximum point, even if you have only 1 or 2 publications. Who has written case, for example, because most of the FIs write case reports. If you have to have a case report, then make sure that you're the first author on those case reports. Make sure that you are they are published in an international journal. Now, till last year, we were not just looking at the where you were in the authorship, we were also looking at the impact factor of the journal. So we used to multiply and used to have a weird scoring system to get you these points. And that actually worked to the disadvantage of some candidates. So we have done away with that. So impact factor is not considered from this year onwards. But remember, the higher the weight of the journal and the higher you are in the authorship, you get more points. With regards to the audits and QIP, again, make sure that they're all within the last 3 years. Make sure that you have completed a loop, because if you're not completed a loop, you don't get full points, you get only half the point. In addition, it needs to have the covering letter to say that it's been done under the supervision of so-and-so, and there's a certificate or something. Finally, if you have actually managed to publish it, or it is in the intranet of the hospital that you were part of and the guidelines have been adopted, or if you have actually presented the QIP results at a meeting, you get the full 5 points. So remember, QIP needs to have a full cycle. All the recommendations should be there and should be very, very clear as to what your role was. You should not be just one of those people who are sitting at the back and doing nothing and just collecting data. You need to be the one who needs to have had a significant input, and that information is provided by your supervising consultant. Thank you. Next. Presentation. Again, all presentations are important. Higher the a lot of meetings were international in the last 2 years, were virtual in the last 2 years. So people managed to actually sit at home and present an international, and they got maximum points. So depending on where you are presenting, depending on whether you are presenting as an oral poster or as an oral presentation or as a poster that you are presenting verbally is still counted as a poster, because a lot of posters these days, they ask you to present a verbal, you have a short, either recorded verbal presentation, because that's how the virtual world works. However, if you have an oral presentation where you are the first author at an international meeting, again, you get maximum amount of points. And the points keep halving. For example, international meeting, oral presentation, you get full mark. International meeting poster, you get half mark. or if you get 3 points for an international meeting, you get 1.5 for a poster at an international meeting. Again, similarly, if you're presenting at a Royal College meeting, which is a national meeting, if you're the first author oral presentation, you get 2 points. But if you did a poster presentation, you'll get only 1 point. And similarly, if you are the second, if you are presenting at a regional meeting, an oral, you get only 0.5 marks. So again, number of presentation you add up and we give a cumulative score. Then the last domain is education and teaching. If you have done a PG cert, I know a lot of you actually do PG cert in medical education, you get 3 points for it. So I know you spend £1,800 to do it and it takes time, but it gets you the point. And I'm sure it's not just us, but a lot of even surgical specialties and medical specialties also look at it kindly. If you have written a book or you've been on teaching the teachers course, you get points for it. I can't remember exactly how many points, but I think it was between 1 and I think it's 2 points for it. If you have a formal role in examining undergraduates, again, you get some points for it. You've written a chapter in textbook, then you get a point for it. Finally, this is left to the discretion of the person who's looking at your folder to see how easy it was for me to look at your poster and to say whether the layout and the quality of the portfolio was great, the evidence portfolio great, or I had to struggle actually, or they had put one thing there and second thing here and repeated. Now, remember, for example, if you cannot claim points in every section for the same thing that you've done, because we are quite easy, we are quite smart in teasing that out. We can pick that up and we'll give you a point at one place and we'll write a comment saying already points awarded in that domain. So we'll not give you the points even if you have repeated it in a different domain. So do away with that habit. And so that gives you that's the evidence folder completed. So is the major bulk of your scoring. That's out of 50 marks, 50% of your scoring happens in evidence. So make sure that you can't actually start collecting evidence just before you're about to put the application form in, because it's too late by then. Next one, please. Which we are all involved as your online assessment. Now, till 2 years ago, all this used to happen in Bristol. We all used to go to Bristol and sit around a panel and used to have questions and answers. It's all done away for the last 2 years. So everything is online. So you have a patient consultation that involves using an actor, and most of the questions are generic. They are not specifically testing your ophthalmology knowledge. They are testing your knowledge of how you break bad news to a patient, or how you, again, this is a very generic thing, or if a wrong drug has been prescribed or wrong eye drops have been prescribed, or patient is unhappy about not getting an appointment in time. So it takes so you get 2 minutes to look through the scenario, then 6 minutes to question, and I as an assessor do not participate in the interview. I do not actually I just watch how you interact and we do the scoring. And this constitutes about 30% of your marks. So this is all I have to say. So you have 3 things so if you want a career in ophthalmology, you want to get into the ST ladder, the work starts from day 1 of FY1. You have to make your mind up that I want to do ophthalmology. A lot of generic, which you will do for getting into the ST rotation, and they're not specific for ophthalmology. Thank you. I'm happy to take any questions.
Thanks, Naren. That was really a great talk. Please, we have about 6-7 minutes to spare whilst our next speaker gets on board. So any questions through the chat box or just speak out. I'm sure some people would be interested to do ophthalmology.
Or maybe I've scared them all.
Any questions at all? If there's no questions, then thank you so much, Naren, for your time. I hope you feel better soon.
Thanks very much. Thank you.
And I'll try and spot our next speaker and see if they're ready to crack on. Thank you. Josh, are you around?
Oh, hi, Dr. Thacker. Yeah, I'm
Hi.
here.
Do you have screen sharing on?
I have sent it to you. I've not used Zoom since the lockdown quizzes that were a fad back way back when. So
Okay.
maybe I can try it, but if sometimes it doesn't come out perfectly. So if
can you see screen sharing on your Zoom?
yes.
Yeah. Open your PowerPoint and try that. If that doesn't work, then I'll run it for you. It should be pretty straightforward. You should have your PowerPoint open beforehand. Okay. So we are very much on time, so not late at all. And Josh is going to talk about obstetric emergencies. Is that working for you?
I'm just going to try it now. So tell me if you can see it.
Yeah. So just see the share screen or green colored sort of thing. If you click that, you might see your PowerPoint in a selection area. And just click that, and you might then be able to.
Let's see. Sorry, just system preference security.
All right, take your time. Is the PPT open?
Yeah, it's just a security issue on my.
All
I
right.
just haven't used it in a while. Just give me 1 sec. Right, that should have made it better now. Right, let's see if we're there.
Right. Yeah, that's it. We can see that. Thank you very much. Off to you.
Perfect. Right, so we've got about a good 50 odd people on here, haven't we? I say a few familiar faces, a few familiar names I can see there. Beatrice, Anna, and a few others. So, right, so hi everyone, my name's Josh. I'm one of the ONG-ST5s, and I'm going to give you a talk on obstetric emergencies today. So, you know, you're coming towards the end of your foundation years, and the time really does fly. I can actually remember being in this very same training day with Dr. Thacker in Dewsbury about 6 years ago, when we were talking about the Ruckle score and Timmy's score and all these other things that I don't really do now, but I still have an awareness of because of that. So just a brief bit about your foundation years. As you're well aware, you know, you have a mix of medicine, surgery, acute services, community services, and these are the things that are going to give you that solid grounding for your future career. And the approaches that you're going to have, that you're going to develop in these 2 years, are what are going to take you through into whatever it is that you decide to do. And I'll be honest, I'm sure there'll be some of you who have an interest in obs and gynae, and there'll be some that have no interest in obs and gynae whatsoever. And some of you will be thinking, why is there so much today? Well, a lot of common things when I get referrals about very mundane, straightforward things, these are the common things that I get told. I've not done it since 4th year. I've got no idea how to approach these problems. It's so specialized. So, you know, if you can take some of the very small things away today, you're not going to be able to manage these uber complex things, but very straightforward things, you'll have an idea and some sort of framework about how to do that. So, you know, do take it on board, even if it's something that you don't really have that much of an interest in, because it will make a difference in your future career. And just for a bit of demonstration, these are some of the things that I saw in my foundation years. And when I'm running the labour ward overnight and it's just me, I'm the most senior doctor there, and people come in with a number of other medical problems, I'm the one that has to deal with them. So you can see how these things pop up. Viral encephalitis in ED, necrotizing pancreatitis on my general surgical placement. The pain-induced Takatsubos was a lady who had an ovarian cyst. And it was very simply, she has a cyst, she has pain, she goes to gynae. What they left out was the fact that she had severe chest pain and ST depression and a troponin of 500. So this woman actually ended up going across to CCU at Pinderfields. So you can see these cases and how they unfold. GI bleeds, acute psychosis, and laparotomies. So you get a wide range of things in your training, and just try your best to take those nuggets forward with you. And even if it's not the specifics, just the general approach to a sick patient or an unwell patient. So let's briefly, before we go on to the emergencies, let's talk a little bit about some of the really general things so that you've got a little bit of context. So Obstetrics 101, what's the point of it? Why is it there? So what we do is, and talking about antenatal care, is we deal with patients that are defined as high risk. Now, patients are defined as low risk until they're found to be high risk. But a patient can become high risk at any point. So if there's a new problem with the baby, i.e. the baby is small, measuring small, there's placental problems, etc., they become high risk and we have to manage them as such. If a woman develops diabetes in pregnancy, that's not uncommon, they become high risk. We need to do extra scans, we need to monitor them, we need to, we need to find what the cause of these problems. If a woman develops orthopnea, decreased exercise tolerance, we're concerned, could this be some sort of new cardiac related problem? They become high risk. Are there any pre-existing problems? Does this woman have brittle asthma? She's been admitted to ICU 3 times. Kind of the thing that we need to know about. Do they have surgical problems? Has this woman had 5 hernia repairs because she's a BMI of 50? Well, that's going to make a difference when it comes to doing the cesarean section. Does this woman have some sort of spinal fusion, which means that she's not going to be able to have an epidural, she's not going to be able to have a spinal? These are all things that we need to deal with, because in labour, if they are not optimized, that's one of the most stressful physiological times a woman can have. So we need to be sure that we've optimized these as best we can, and that we have an awareness and a preparation for when these women come onto our labour ward. So what's the benefit of this? We're optimizing these women before birth. I'm sure we're well aware prior planning prevents extremely poor performance. And that's demonstrated here. So these are my 2 countries of heritage. One is what we consider at the forefront of a developed country, and Nigeria is one of the most populous, one of the most developed countries within Africa. However, it has extremely limited antenatal care. So I can compare these and openly say, the difference and flaws there. You can see maternal outcomes, 7 deaths per 100,000 pregnancies in the UK. Compare that to 114 per 100,000 in Nigeria. Better fetal outcomes, only 4 deaths per 100,000 per 1,000 births here in the UK. Compare that to 56 deaths per 1,000 births in Nigeria. So you can see that the presence of antenatal care, which is the involvement of medical team, obstetric team, midwifery team, anaesthetic team, makes a big difference. So there are 3 trimesters in the pregnancy. First trimester, 0 to 12 weeks. This is where all of your kind of DNA synthesis, your organogenesis are occurring. And this is where there are the highest risk of errors in these developments, which is why the risk of miscarriage is so high, 1 in 5. And it's also why people often don't announce they're pregnant until they've had their 12-week scan, because it's kind of acknowledged that once you get past that stage, your risk of miscarriage is much lower. Your second trimester is from weeks 12 to 26, and from the third trimester is 26 to 28 weeks onwards. There's always a question around when is a baby truly viable, i.e. if it was born, would it survive? And we see lots of kind of advancements in neonatal care. However, it's a bit of a grey area. We would say around 23 to 24 weeks is true viability. Things that are advantageous are being of a female sex, believe it or not, and being over 500 grams. Because it generally suggests that, you know, you're of a size whereby your lungs are much more developed, and therefore you're able to progress much better and deal with kind of intubation and things that occur afterwards much better as well. Because we know that prematurity is the biggest cause of neonatal mortality. So the most common birth routes. So it may surprise you or may not surprise you. A vaginal delivery, 52% of all pregnancies. Probably not as many as you thought. 14% are instrumental deliveries, and this basically means when a baby is fully dilated, mum's been pushing for a while, but for some reason the baby won't deliver. What we use is either a suction cup, which can be called a kiwi or a ventouse, on the top of the head to pull baby out, or we use what I told the women are salad tongs, but they're essentially forceps which go across the top of baby's head, and we help to guide the baby out vaginally. The remainder, which is 34%, are cesarean sections, and that's a mix of both emergency and planned cesareans. You'll hear this kind of phrase, normal birth, and it will have been in the news recently if you've heard about the recent Ockenden report. And this is a kind of an incorrect term. When they're referring to normal births, we're talking about physiologically normal, i.e. the birth has gone as it should do in the textbook with no complications. However, we know as we study normal physiology and abnormality and pathophysiology, we know that this doesn't always occur. And the challenge comes when we know that there's an issue with the delivery, but we're fighting against other issues that are in the way and stopping us from doing a very difficult job. So you have a pregnant patient on your ward. So what are your worries? Anyone going to shout out what their worries are? Moira, what about you? You're the name that's underneath my picture, so I'm going to pick on you.
So it's kind of which drugs I can give them, and especially at what point in the pregnancy, and changes to dosing. And like when it says to give it at mum's like actual weight rather than the weight she is now, and things like that.
No problem. What about you, Polly? Anything else?
I guess if they're on like a general ward missing like pregnancy specific complications, so like if I'm on A&E at the minute, so like if it's a pregnant person with like abdominal pain, is it pregnancy related, or am I going to miss something else because like I'm overshadowed by thinking about the pregnancy?
Of course, understandable. And who else? Jack Eclid, what about you? Oh dear, Jack, you're not with us. All right then, what about you, Cameron? Ooh. Okay, well, that'll do. So we treat them like any other patient. Can everyone still hear me, by the way?
Yeah.
Yes. Cool. Sorry. Right. So I would say, you know, those are really understandable concerns. And I would advise you to of course, acknowledge they're pregnant, but treat them like every other patient. And we'll go into that in a little bit more detail. So first things first, and this is not a complete history, but these are just some very basic things. If you're concerned with those concerns that you have, you're going to ring me, and you need to know some very basic things. So what number pregnancy is this? i.e., how many pregnancies have they had before that have gone to full term or past that 24 weeks that we've mentioned? If this is her first pregnancy, great. What gestation are they? Are they in that first 12 weeks that we just talked about where they're at high risk of miscarriage? Are they in that second trimester? Are they in that third trimester? As you said, this is going to dictate necessarily some drugs that we might give in the first trimester that we might not give in the third trimester. And then, have they been seen in an antenatal clinic? This is going to tell you, if they've not been seen in an antenatal clinic, they're probably low risk, aren't they? If they have been seen in an antenatal clinic, then the question will be why? I've got a dilated aortic aneurysm because I've got ethylene loss. Pretty high risk. So these are some of the things that you're going to see really commonly on your wards. So reduced fetal movements. Now with this type thing, this is one specifically that they're going to have when they come in with a different problem. And you're not expected to do anything for this. You would just simply contact us, and we would either have a listen in if it's before 26 weeks, or do something called a CTG, which basically tells us how baby is doing at that time. With pain, you mentioned about in A&E. I would suggest, in the first instance, approach them like anybody else. If this is a patient with a BMI of 50 and they've just had a doner kebab and they come in with right upper quadrant pain, pregnant or not, it's probably biliary colic, isn't it? If they come in and they've got right flank pain, yes, they're pregnant. They've got 1+ of blood. You need to consider, yes, this could be a pregnancy-related problem, or it could be, a renal stone. So I think my point is just that we need to be not just saying immediately, great, they're pregnant, let's send them off to obstetrics, because this is where things become a problem, where we miss other presentations that, and yes, we can do some things as well, but actually we're trying to do what's the best for the patient, not just what is getting down waiting times or getting them off of your caseload. We're trying to treat the patients in the correct way. So we talked a little bit about analgesia there. So as a general rule of thumb, paracetamol and codeine are fairly safe in pregnancy. If someone's requiring morphine because they're in pain, I would give them some morphine. A baby's not going to become unwell because of a single dose of morphine. Whereas if a patient has severe pain, they become hypertensive, they become tachycardic, that's going to affect the placenta, that's going to affect the baby far more. So giving someone morphine, up the analgesia ladder, paracetamol, codeine, morphine, I think that's reasonable in the first instance in the acute setting. Things to just watch out for, some ibuprofen. So we generally don't tend to give this in the pregnancy, or we try to avoid it where possible. And this is mainly because it closes the ductus arteriosus, which is something which shunts blood away from the pulmonary circulation. So particularly in the third trimester, that's something we would avoid. PV bleeding. So this is a really common one. A woman says she's bleeding. I get a call. I've got a woman who's pregnant and she's bleeding. Okay. How much is she bleeding? Don't know. Okay. Is she stable? Well, yeah, I think so. So I think with anything, if you were ringing a surgical reg about a patient who had PR bleeding, or you were ringing an upper GI reg about someone who had GI bleeding, this would not be an acceptable referral. Okay. I'm not expecting people to speculum patients, but we should be at least asking some simple questions. How many pads have you changed? How often have you changed them? Have you changed them because they're soaked? Or is this because you're, for hygiene? And, actually having a look at the pad yourself is going to give you a lot of that information. And it's just something that's really, really, really quick and really, really helpful. You know, this woman, she's 28 weeks pregnant. She's got a small amount of PV bleeding. She's changed one pad in the past few hours. Now, of course, we're going to come and see her because she needs to be seen by us. But it doesn't mean it needs to be seen right now. Whereas if you're saying this woman is flooding through multiple different pads, you know, that's going to tell you she needs IV access, she needs a group and save, and I'm probably going to come and see her immediately. So these are just some things to think about. Okay. Also, if you do have any questions, I should have said at the very beginning, please do shout out. I don't mind. So useful things. These are just in our trust. So that's the Cisco phone that's held by the OBS registrar. So you may get me on the other end of that phone, okay? Well, a lot of the time. And, you know, we'll try and troubleshoot things where possible. This is a number for maternity triage, which is the equivalent of our kind of maternity A&E. Now, of course, we'll see lots of things that aren't maternity related, coughs, headaches, etc., of women that happen to be pregnant. But say someone, for example, mentioned they're in A&E, someone comes in with a collapsed query cause, you've done your full blood count, your ECG, you've ruled out a fit, they're fine from that point of view, but you just want them to be kind of seen just in case, that's absolutely fine. Give maternity triage a call, they will tell you where to send the patient, and you know, if you're happy from a medical point of view, the patient can make their own way, no big deal. This is something else that's just written here, best use of medicine in pregnancy. So this is for the specifics of things that you mentioned, like antibiotics, other medications that you might not be aware of. And when we're giving medications in pregnancy or pre-existing medications, we really want to know a few different things. Are they going to increase your risk of stillbirth? Are they going to increase your risk of miscarriage? Are they going to increase your risk of birth defects? And are they going to increase your risk of babies that are going to be small for gestational age? Now, the BNF, which is often a go-to for lots of things, will not give you any information. It will say something like, avoid if necessary. How do you know if it's necessary? A patient with treatment-resistant depression who's on venlafaxine, it's quite a difficult decision to make just off the cuff, isn't it? So best use of medicine in pregnancy is a kind of spin-off by a tox base, which is used by ED. And it will tell you all of these things. Literally just type it in now, best use of medicine in pregnancy. It will pop up, it will give you some information that just save you a phone call and makes things much easier for you. Of course, it's not exhaustive, and if there's something you're not sure about, by all means, give us a ring and ask. So that's all the 101 stuff done and out of the way, and we'll get into the nitty-gritty now. So obstetrics, it's always been a challenge, but it's much more of a challenge these days. And this is because we have women at higher risk. A large majority of our population that are pregnant are obese, which brings its own problems, risk of diabetes, risk of cardiovascular disease, big babies, small babies, etc. The scenario changes all the time in pregnancy, and you have in the labor, and you're having to manage lots of different challenges. Have people been escalated appropriately? Are we trying to keep that woman low risk because that's what she wants, when actually that's not what she needs? We've got to manage the women's expectations. You know, they expect a section now. Okay, well, we've got other things that are more urgent or more pressing. The technical challenges for you who want to be an anaesthetist, trying to do an epidural or a spinal on these women who are increased BMIs. Technical challenges in terms of actually doing the cesarean sections. Multiple cesarean sections mean more difficult surgery. These are all technical difficulties that we face on a daily basis. And of course, appropriate debriefs. So in terms of as a medical specialty or with our midwifery colleagues, you know, we really struggle to get the cut through to all of the patients that we need. All you need to do is type in Mumsnet and have a look at what's being discussed on these forums, on home birth forums. You know, facts, things that are just completely wrong. But because they're being told what they want, it's really, really difficult for us to then be able to manage those type things. So when things go wrong, it's trying to debrief the women in an appropriate way that help them to understand what happened and why it happened, without saying this person is to blame or that person is to blame, and also trying to learn from these things as well. So those are the challenges, but some of the things that are also, you know, a good obstetrician relishes that challenge. So the first thing we're going to cover is postpartum hemorrhage. And this is essentially, as it says, postpartum, so after delivery, hemorrhage, bleed. So this is defined as bleeding of over 500 mils after delivery. The primary PPHs are those that are within 24 hours of birth, and the secondary ones are those that are over 24 hours of birth. But most commonly, it's the primary ones that we are dealing with. As you can see there, 500 to 1,000 mils is minor, and anything over 1,000 mils is classed as major. And that will vary slightly from trust to trust. So why does it happen? You have the 4Hs and 4Ts of cardiac arrest and resuscitation. We have the 4Ts of PPH. And these all kind of correspond to the reproductive tract. So if you imagine the uterus that's here, the cervix, and then the kind of vagina. So the first one that's most common is tone. You've then got tissue, trauma, and thrombin. So why is it important? Well, to put it simply, women die. It's the leading cause of maternal mortality in low-income countries. And that's put simply because a lot of the things that we use here, such as oxytocin, things that help the tone of the uterus to contract down very well, they require a fridge. And in a developing country, if you don't have reliable electricity, you can't store that medication, therefore you can't give it. In much the same way, if you don't have electricity, you're unlikely to be able to afford the oxytocin as well. So that's something to consider. In developed countries, why is it important? Well, although the women don't die, it does affect their morbidity. So they have a higher infection risk, they need blood transfusions, longer hospital stays, and we all know the longer you stay in hospital, the higher the risk you have of other things happening. We can all think of an 80-year-old patient on the ward who fell when they were in for a COPD exacerbation, ended up with a fractured hip, ended up with confusion after delivery, and never left the hospital again. So although it's not quite the same in our women, we still want to minimize hospital stays wherever possible, because being at home is better for everybody. So tone. So the uterus itself has a supply that's very, very rich. And we talk about 700 to 800 mils a minute, which is why if you deliver on the labour wards, you'll always have a grey cannula in your hand. Because if you're losing that amount during labour, you've lost your circulating volume in a matter of minutes. After delivery, the vessels that supply the placental bed and the endometrium actively bleed. So what we need is that uterus that's kind of big and boggy at the top here. We want that to contract down so that these blood vessels are constricted, and that minimizes the amount of blood that is lost vaginally. So with that in mind, anything that prolongs this time is a risk factor for PPH. So if you can think about these, so if you imagine you've had a huge baby, delivered a 5-kilo baby 2 days ago, a 5-kilo baby is substantially bigger than a 2-kilo baby, isn't it, inside that enclosed space. So once that 5-kilo baby is left, there's that big theoretical space that things need to contract down. So therefore, that baby, that risk factor of having a large baby is going to cause you potentially to bleed more. If you've got twins, multiple pregnancies, more space occupied, higher risk of a higher risk. A woman who's got a large BMI, she's going to have fatty infiltration into the uterine muscle, like every other muscle that she has in her body. It's not going to contract down as well as it should do. A woman who's had a long labor, that muscle is tired. It's going to take a long, long time for it to contract down. You get the picture. The other thing to say, the uterus sits here, the bladder sits in front of it. If the bladder is very full, the uterus that sometimes has flopped over the top of that can't contract down. So we also give a catheter at that point as well to help with this. So we talk here about prevention and prediction. What can be done to prevent PPHs via tone? We need to try and assess those people that are at higher risk. So we've talked there, gram parity, which means people who have had multiple pregnancies. Multiple pregnancies have a tired uterus. The uterus stretches more, the muscle is more tired, it takes longer to contract down. Babies that are malpositioned, So if the baby is transverse, so it's lying sideways rather than longitudinal as it should do, you're stretching the uterus in a way that it shouldn't. So even after you've delivered that baby, the uterus is stretched in an abnormal way. So we need to try and help that contract down. And of course, like with anything, if you've had something before, the risk of having it again happens. So previous PPH. We need to try and make sure that there's an appropriate birthplace for these women. And of course, that's labour wards. And with any bleeding woman, IV access, group and save, full blood count. So treatment. We talk about a tired uterus or uterus that's slow to contract down. So what we do is we give uterotonics, medications that encourage the uterus to contract down. So in this case, we use something called oxytocin that helps immediately. There's something called an oxytocin infusion, which gradually works over a period of time. And then we have some extra medication down here, ergometrin, carboprost. These are 2 extra medications which can help with that process. Misoprostol is something that's given PR. It's something that's used really, really regularly in third world countries. Again, because it's readily available, it doesn't require electricity. It doesn't require a fridge. So that's why that's there. But often that's a last resort. Sorry. So tissue. So in this case, what we're talking about is something that's still within the uterus, preventing that from contracting down. And often that's something called the placenta. Now we know this is something that feeds the baby, and after the baby is delivered, the placenta has to come out. If the placenta doesn't come out, again, that's distending that space of the uterus. So what we do is we wait for a period of time, 30 minutes if you've had active management, or 60 minutes after physiological. And that size written there because ultimately it's been shown to have a clear benefit. I can't think of any reason why somebody would refuse it. So retain placenta. Now, something else that can also cause that is also uterine clots. So this is when there's been bleeding after the delivery into the uterine cavity and that blood has already clotted. Sometimes it may be while you're waiting for the placenta to separate. The clot gets stuck inside and then you're not able to remove it, initially anyway. So in these scenarios, what we do is we try our best to remove the tissue by pulling on the cord in a kind of controlled manner. This is called controlled cord traction, or by doing a manual evacuation, which is where you kind of use 2 fingers or a whole hand inside the uterus with good pain relief, of course, to remove the clots that are in the womb. And as it says there, prompt vaginal examination, evacuate the clots. If blood loss is minimal or maximal, then start making plans to move to theatre. And we would hope we would already have IV access and group and save. Trauma. Now, this is actually really, really common in labour. And again, it's not something that's talked about because it's not classed as glamorous. It's classed as being very negative, but that's, this is a fact. So 1st degree tears are just to the vaginal mucosa. 2nd degree tears are to the vagina itself and the perineum. The perineum is basically the bit that's between the bottom of the vagina and the anus. So the perineum is that bit in between. 3rd and 4th degrees essentially involve the muscles of the back passage and of the mucosa. We do a episiotomy, which is a cut that goes from the bottom of the vagina away from the anus to encourage stretching and space away from that rectum. And that is essentially an induced 2nd degree tear. But that will heal once we repair it much easier than a 3rd or 4th degree where a woman will have symptoms up to a year or longer afterwards. As again, trauma, we will assess the vaginal tract and the perineum, we'll do a PR to assess the muscles, and we will repair this in theatre or in the room that they've delivered if necessary. Thrombin. This is like any other excessive blood loss. You'll see that there's a change in the appearance of the blood. Rather than it being that kind of metallic, dark red colour, it will suddenly be bright red, very watery. And we all know that's because you've lost your clotting factors. You would hope that you've had some good dialogue with your anaesthetist at this point, and they're replacing the factors that you think you're losing from the top end while you're sorting out the problem from the bottom end. So always have good dialogue with your anaesthetist and with the team that's around you. General management. So with any bleeding patient, whether it's PR, PV, GI, anywhere, you know, I still remember that kind of AD on the floor and 4 more. There are the 4 cavities you're bleeding into. A, B, C, D approach. Deal with the things that are going to kill you first. What's the blood loss so far? Do we have a cannula and group and save? Let's get those things sorted first as a priority. I think I went down to A&E with a ruptured ectopic once, and they said, we'll do the A to E and you sort out the V, which was, you know, I did chuckle, but it was a fact. You know, they sorted out that bit while I was able to sort out the bleeding vagina, and that was kind of an ectopic pregnancy acute scenario. So in the abdomen, is the uterus boggy? Yes. Well, let's deal with that with the uterotonics we've talked about. Vaginal examination, trauma and tissue, and then we can think about uterotonics and catheter. So acute emergency. So these are the ones where we absolutely have to run to theatre and deliver the baby. So a deceleration refers to babies to their fetal heartbeat. So fetal heartbeats run between 110 to 160 beats per minute. Now, in response to a number of other problems, baby's heartbeat can drop, and that typically recovers in most cases. But if it lasts longer than 3 minutes, that means that baby is not getting the oxygenated blood that it needs to perfuse its heart and its brain. Prolonged bradycardias will lead to fetal hypoxia. And by that, we're talking about cerebral palsy in various different severities. So this is why we have to really run with these cases. Things that can cause this, anything that can affect the blood supply to the baby. So typically, if a mum's dehydrated, we need to hydrate her to make sure she's got a good blood pressure, which will perfuse the placenta, which will perfuse the baby. Sometimes they're given an epidural, which works really, really well, but can drop their blood pressure. It's not always shown as dropping their blood pressure, but we know that it reduces their blood supply. So we need to try and optimize that. If there is a uterine cause, baby is the uterus is contracting excessively. That then means that blood is not going through the cord to the baby, and suddenly you've got a problem. If there is a rupture to the uterus, the blood is not going to the baby because it's going out into the abdomen. So we need to deal with that. Similarly, with a placental abruption, if you imagine you have your endometrium here, your placenta inserts into there, and then the cord is supplying the baby. An abruption is where you get separation of the placental bed from the lining of the womb. So if you get this separation, again, the blood is coming out here into the uterus and not into the baby. So suddenly we need to deal with those issues. And this is a very simple rule, 3-6-9. At 3 minutes, the midwife calls for help. 6 minutes, we're in the room assessing, deciding, are they dilated, are they not dilated? At 9 minutes, we're making preparations to move to theatre. And at 12 minutes, we're delivering. So from a bradycardia occurring, everyone's in the room, getting access, getting the patient to theatre, giving them a spinal or a general anaesthetic, and I'm cutting into the abdomen and getting the baby out in 60 seconds. So this is something that is really, really, really an acute emergency. We would always much rather do all of this and the baby come out screaming as a kind of false alarm than wait and wait and wait and the baby comes out in poor condition. Right, moving through. Just a few more slides now. So cord prolapse. So this is basically referring to where, as we talked about here, you can see in picture A, you've kind of got the endometrial lining, which is the outer region. You've got the placenta, and then you've got the cord, which carries the vessels that take oxygenated blood to the baby and also take it away from the baby. Now, cord prolapse occurs when part of the cord can come through the cervix into the vagina. This is a problem because the change in the pH and the change in the temperature also cause vasospasm of these vessels. If you get vasospasm of those vessels, the issue is that then you get impaired gas exchange. So oxygenated blood doesn't get to the baby and carbon dioxide is not taken away from the baby. So you get buildup of that carbon dioxide, carbonic acid, metabolic acidosis, which affects baby's brain, and you don't get oxygen to the baby. The only treatment for this is an emergency cesarean section. We get the women to turn onto their front and essentially put their bum in the air. So if you imagine this is, I know I'm kind of on the, imagine this is where we're examining, okay? And the cord has come out here. What we do is we get the woman to turn onto her front. So this is woman's head. This is a head facing the bed. And we get them to put their bum in the air. And the reason for doing that is if the cord has dropped out, by getting them to put their bum in the air, we're trying to get gravity to help it drop back towards the uterus, and also to get the head off of that cord so that we've got a little bit more time to minimize that kind of mass shock that we've just talked about and deliver the baby. And you can see here is what we've just talked about. Mum's bum is in the air, head on the pillow, and we literally run them down to theatre with somebody displacing the head off of the cord, get them onto their back, a GA section, and the baby's out in no time. So I think this is the last one now, and we're nearly there. So shoulder dystocia. Now, these are really, really nasty, or they have the potential to be really nasty, and they're every obstetrician, or every midwife, but every obstetrician's nightmare. They can occur in 0.5 to 0.7% of all pregnancies, and they're difficult to predict. Things that we do know increase your risk are having a big baby, having a baby that is diabetic and also big, and also induction of labour. And it's defined as a prolonged head to body delivery time. So as you can see from this diagram here, what essentially happens is the head of the baby is delivered. You can see that baby's head is outside of that kind of vaginal canal. But the anterior shoulder, the shoulder that is forward most in mum's abdomen, is stuck underneath this pubic symphysis. Now, that prolonged time becomes an issue because baby, again, that overall picture without oxygen, with carbon dioxide, risk of brain damage. So we have to do a number of different maneuvers and positions to try and help deliver the baby. The issue with that is traction on baby's head can affect, and this is going to be testing your anatomy, affects your brachial plexus and the anterocervicalis, which is something that I think we covered back in second year. Now, that's because of the panic that occurs at the time. And the longer this goes on, you become more worried, less so about brachial plexus injuries, but actually chronic fetal hypoxia and potentially death. So the strain on that can cause nerve palsies to baby's arms. And most commonly, that's the anterior arm that's affected. So this is a really helpful mnemonic helper where you essentially call for help, evaluate for an episiotomy, which is that cut we talked about, which is going to increase the space that you have. And we put the legs into something called McRoberts, which are a position which increases the diameter of the pelvis, because it's that increase in space which will help us to try and free up that anterior shoulder that we've just talked about. Suprapubic pressure. So very much you can give this in a controlled manner with two hands like so, or you can give it in a rocking motion like you would in CPR. E is for entering to do rotational maneuvers. Now, if you can imagine, the vagina is a closed space. Someone like me who's got very big hands, it's going to be really, really difficult. And that is a skill in itself. All of this while happening at the same time with lots of people in the room. Some people try to remove the posterior arm. So if you imagine this is the shoulder that's caught and it can't move. If I free this posterior shoulder, suddenly that shoulder that's caught has now come out of the way, and now we can deliver the baby. If you're getting down to here and things haven't gone well, you're basically repeating them, but turning the woman into a different position. Just for your benefit, this is McRoberts' position. And to be fair, 90% of all shoulder dystocias are resolved with this. So that's the position where we've got the woman with her knees right up towards her chest. This is the initial angle on the bottom left, And by bringing the patient's knees up, you can see that that theoretical angle and amount of space in the pelvis is increased. So that's a very, very whistle-stop tour of some of our emergencies, and just some little nuggets in terms of when you see obstetric patients on your ward, and also some other considerations and little nuggets that I've picked up along the way. So I hope that's helpful. That's my email address there. If you have any questions, I'm always willing to try and, you know, if you're keen on obs and gynae, to try and get you some hands-on experience, any advice, interview preparation, more than happy to do that. So more than happy for any questions. Otherwise, it's over to you, Dr. Thacker.